the headlines where we're going to discuss new data on targeted systemic treatment for early stage resectable non-small cell lung cancer. I'm Josh Sabari. I'm a thoracic medical oncologist at NYU Langone Health Promoter Cancer Center, and I'm joined by my colleague, Dr. Ibiayi Dagogo-Jack. Ibiayi, do you want to introduce yourself?
Hi, everyone. I'm also a thoracic oncologist, and I am at Massachusetts General Hospital in Boston, Massachusetts, and glad to be with you today.
And welcome to this discussion. So what we're going to do is we're going to talk a bit on early stage disease for about 20 minutes or so. And then really we want to open this up to you for questions. So if you look at that comment section, if you can put your questions in throughout, we will get to them at the end of the discussion for questions. So the focus of today's discussion is really outlined here. We want to talk about biomarker breakthroughs across the disease continuum. We're going to talk about some of the unmet needs in early stage disease. We'll talk about advances in targeted therapy, particularly in the adjuvant setting, and maybe we can even think into the future in the neoadjuvant setting. And then clearly we'll tackle some of the questions from the audience. So really looking forward to the discussion. Ibiayi, looking forward to sort of moving forward here. So tell me about, where have we become or where are we going in the early stage setting, particularly in regards to molecular testing? Tell me about your practice.
Yeah, so I think molecular testing is something that we used to reserve for the most advanced stages. So here I'm speaking kind of about stage 4, right? It has been really the mission of the thoracic oncology community to make sure that every patient who has a stage 4 lung cancer gets broad molecular testing because we now have multiple targeted therapies. We also know that some types of therapies like immunotherapy may work better depending on expression of biomarkers like PD-L1. And so the last few years have really focused on moving some of those therapies to the earlier stage setting. And that has really made it incumbent upon us to do that similar molecular testing in the early stage population. We know now that non-small cell lung cancer is really an umbrella term, right? It really encompasses multiple different diseases, multiple molecular subsets. And it's very important to define the precise type of cancer that someone has.
Yeah, so I agree. I mean, in the metastatic setting, targeted therapies have revolutionized, outcomes for patients, both improvement in quality of life, but also importantly, improvement in survival. And clearly, we need to do better. But in the early stage setting, do you think the move of targeted therapeutics into the early stage setting, are we starting to think about cure, right? Because a lot of our early stage patients, the goal and the hope is curative in its intent.
Exactly. And I think for years, right, for decades, all we had was chemotherapy in this space. And while chemotherapy improved the cure rate relative to surgery in the setting, I think all of us would agree that we could do better than chemotherapy. And we see how well some of these targeted therapies work in the stage 4 setting. And the hope is that by maybe appending them or adding them on to chemotherapy or maybe substituting them for chemotherapy, that maybe we can increase the proportion of our patients who are cured after surgery.
So in an early stage patient, a patient who has stage 1, let's say B to 3A disease, how are you thinking about, testing or biomarker testing in that patient population? We know clearly in the metastatic setting, there's very clear guidelines for broad panel next generation sequencing, PD-L1 expression. But now taking this into the early stage setting, is there sufficient data for us to do this broad testing? What are you doing in your clinical practice?
Yeah, I think it's a very good question, Josh, because now we have almost kind of two types of paradigms for treatment in the early stage setting, right? Either you go straight to surgery and you do all of your systemic therapy afterwards, or you do what we call a perioperative approach, where you do some therapy, typically chemo and immunotherapy, unless you're on a clinical trial, and sometimes you do targeted therapy up front, and then you do a little bit after. And we know that as far as chemo immunotherapy, there are some molecular changes in the tumor, molecular alterations in the tumor, that were biomarker that we've talked about, that might steer us away from an immunotherapy-based approach. And for patients who go straight to surgery, there are some biomarkers, specifically EGFR and ALK and PD-L1, that we pay attention to dictate and kind of decide what treatments to give after. So I think at the bare minimum, we should be doing PD-L1, EGFR, and ALK testing. But frankly, I actually think if we can get it covered, it's helpful to get as broad as possible to do similar next generation sequencing, because there's many clinical trial opportunities in this space as well. And I envision a future where we're broader than just EGFR and ALK targeted therapies.
I couldn't agree more. In my practice, I am obtaining broad panel next generation sequencing. There is some sort of back and forth with insurance companies and payers about reimbursement and sort of, cost and access. But I agree with you, right? In the metastatic setting, we're obtaining broad panel NGS on everyone. Why shouldn't we be doing that in our curative intent population, where we'll talk a lot about the data in EGFR and ALK in the adjuvant setting, but maybe there are other opportunities in the future currently being investigated on clinical trials. Ibiayi, you brought up the idea of, this immunotherapy paradigm. I know we're focused today on targeted therapy, but why does that matter? I mean, why does it matter whether you know the genetics up front in a patient with early stage disease? Can't you just give everybody immunotherapy or chemo and immunotherapy in the neoadjuvant setting and then wait for the resection results and get testing after?
I think it's a very good question, and I think one that we've teased out. So a lot of what we are saying is borrowed from the stage 4 setting, where people have done studies, retrospective and prospective, that have really demonstrated that giving immunotherapy to certain populations of lung cancer or subsets of lung cancer, EGFR and ALK being kind of the key examples here, but also probably applies to ROS1 and other molecular subsets, that tumors with these alterations don't benefit as much from immunotherapy. And there's a lingering effect of immunotherapy. It has what we call a long half-life. And so when you end up starting that therapy that was indicated, so that targeted therapy, you can actually have more toxicity. Things like serious toxicities like hepatitis or liver failure, pneumonitis, lung inflammation. And so it's made us very kind of proactive about doing molecular testing in the stage 4 setting. And I think that certainly applies to the resectable disease setting, where I think the stakes are even higher, right? Where we're trying to cure people and we don't want to deprive them of the best therapy to get that cure.
Yeah, so I agree totally. I think in the metastatic setting, we've learned, over time that we don't want to utilize targeted therapeutics in the, driver negative population, right? That's an advance that has happened over the last 10 or 15 years. We want to biomarker select our patients. But, the vice versa is true, right? We don't want to use immunotherapy in our patients who are mutation positive, that have actionable driver mutations. And I think taking that same sort of rationale into the early stage setting, if you have therapies in the metastatic setting with 80% response rates, why not utilize those in the early stage setting to hopefully drive or improve the cure in this patient population? So, Ibiayi, take a patient that you see in clinic with early stage disease. What pieces of information do you know, and how do you think or talk about that with patients? Because we know a lot of this takes a long time to come back.
Yeah, I think the key point is that it's very much a multidisciplinary visit when I see patients with early stage disease. And what I mean by that is just not me, right? It's me, a surgeon, often radiation oncologist weighing in as well. We communicate a lot with our pathologists to figure out the stage of the tumor, and molecular pathologists to figure out what molecular alterations are present. I tell the patient that we might not have all the information up front, but we will get it as speedily as possible because we know that time is critical here. And we want to be as informed as possible before we move forward. And so at minimum, as I mentioned, I want to know the exact stage. So I want to make sure the nodes are staged appropriately. I want to make sure I have all the testing, right? I don't want to kind of cut corners in terms of making sure there's no brain metastases or other things. And I want to know kind of what is the molecular makeup of the tumor, and that's the NGS or next generation sequencing we're talking about. And for those with kind of driver negative tumors, PD-L1 status, right? And there are some, I don't want to put out the false idea that all molecular drivers are equal. So there are some molecular drivers for which immunotherapy is still the right answer. And so I want to have all of that information in hand before I make that decision as to how to proceed.
Yeah, and we know that in early stage disease, the rate of driver alterations is similar in the metastatic setting. So, for example, EGFR rates, 10 to 15%, maybe even 20, 25% in New York and Boston, maybe 40%, for example, in China. We know that there are similar rates of these driver alterations in the early stage setting. And again, the idea here with early molecular testing is that we have the potential, right, to actually reduce the risk of recurrence and improve survival. We're moving away from a paradigm where just using adjuvant chemo, and how frustrating is adjuvant chemo, Ibiayi? We never really know if we're driving response. We're giving therapy that has only toxicity without a potential known benefit to the patient, whereas adjuvant targeted therapy, it's biomarker selected. And, just curious, are you using these off-label in the neoadjuvant setting at all before surgery?
I think this is a question that comes up quite a bit in our weekly tumor board, right? We know how well these therapies work in terms of shrinking tumors, but I also think that we need prospective studies. So when I can, I like to use these therapies in the context of a clinical trial, because we've seen clinical trials, including last year at ASCO, that were presented using an EGFR targeted therapy alone as a preoperative strategy. And although there was tumor shrinkage, when you took many patients to the operating room, there wasn't complete kind of disappearance of the tumor, right? And so I think we still have some details to iron out in terms of how best to do them. Is it with chemotherapy? Is it by itself? How long, how many months, et cetera, how many weeks to give these therapies?
I want to walk through the data. So we know there's a significant unmet need in early stage patients, primarily those patients with driver mutation positive non-small cell lung cancer. Can we do more for them in the early stage setting? Can we deepen the rate of potential cure? We know that surgery still will remain a mainstay in this patient population, but how do we deepen the cure here? So we know for patients, and this is the NCCN guidelines for early stage testing in non-small cell lung cancer, for patients with stage 1B to 3A, and even the 3B, those are controversial, right? Borderline resectable cases. But you can imagine for stage 3C and 4, we're doing this testing anyway as our current standard of care. But at minimum, as you mentioned, we should get PD-L1 expression, EGFR mutation, and ALK rearrangement. And you heard from Dr. Dagogo-Jack that maybe getting a more broad panel NGS should be done. Some of these turnaround times are listed here. Turnaround time is the time you send the test to the time it returns. Is this what you're seeing similar in your practice, Ibiayi?
I think that there are pressure points in the early stage setting, and I think that in some ways we have figured out ways to speed it up. I think the key point here is that PD-L1 often comes back before the other testing, and we shouldn't have a knee-jerk kind of reflex strategy to just go based on PD-L1 and say, oh, wow, PD-L1 is high, let's move forward. We should wait for the other test. But I do think that we found ways to get that EGFR and ALK testing down to less than a week to get the results. And sometimes that involves doing single gene assays. If your comprehensive next generation broad panel testing that Dr. Sabari has referenced is going to take 2 to 3 weeks.
It's so hard to sit on your hands when you get that PD-L1 expression back, especially if it's 100% or 50%. Well, what are you telling your patients? I mean, what's the need to wait there?
And I think it's important, right? Because at least in our system, the results are available to our patients immediately, right? And so they will get a ping that says there's a result available. And so they know something is there and are hopeful that we can now move forward. And I think the most important thing I tell people is that we have to get it right? We can't cut corners. We have to put our best foot forward first. And then that is our best chance of getting rid of this. And I think people are willing to wait in that setting, right? And I think when you hear it from multiple avenues, right, you're hearing it from a multidisciplinary team, you know that it's a well thought out, kind of a well-planned strategy, then I think that gives people some comfort. And then to check in frequently, right, to make sure that the symptoms are not escalating, et cetera.
For sure. And I think you're never wrong to give chemotherapy alone if you need to up front to sort of stabilize things. But again, in a patient who has such rapidly growing disease in the early stage setting, maybe reassessing the role for surgery, I think, is important. So, waiting another 2 weeks or 3 weeks in the natural history of a disease that took, many months to years to develop, like you said, I tell patients, I need the right information to make the best decision for you in clinical practice. So Ibiayi, let's jump into the 2 sort of landmark trials in the adjuvant setting utilizing targeted therapy. Let's start with the ADAURA trial first, and then we'll end with the ALINA trial. So walk us through the ADAURA trial, and I'll put some of the data up here. Tell us the sort of impact of the ADAURA trial to you and your patients in your practice.
Yeah, so what I will say is that EGFR, for the most part, has always almost been like the leader here, like leader of the pack, the standard bearer for thinking about targeted therapies. In the metastatic setting, we started with EGFR targeted therapies, and then we brought in from there. And the same is true in the adjuvant setting or the resectable setting. So ADAURA is a study that looked at a drug called osimertinib, which is a drug initially approved for stage 4 EGFR positive non-small cell lung cancer, and asked the question for patients with resectable non-small cell lung cancer, here tumors greater than 3 centimeters or involving lymph nodes, how well do people do? So can we improve what we call disease-free survival initially, and also overall survival, how long people live? The second term references, in the first term, that disease-free survival, how long until the disease comes back or people pass away from the disease, by giving people osimertinib. And because we don't have a lot of informed data, the way the trial was done was 3 years of osimertinib versus placebo, and patients had surgery before this, although it was at the investigator discretion and the patient discretion whether or not they had surgery. We've seen that the patterns of patients who got surgery largely reflect what we do in clinical practice, who got chemotherapy largely reflect what we do. And so most patients who had stage 3 got chemotherapy, and those who had kind of earlier stages may not have necessarily received chemotherapy. But I think what I would say is that this was a slam dunk study, a lot of clapping when the data were presented, in that we saw a significant improvement in disease-free survival first, and now 5 years out, the 5-year data suggests like at least a 10% improvement in overall survival at 5 years. And if we want to look at the numbers specifically, in that stage 2 to 3 population, it went from 73% to 85% just by using that 3 years of osimertinib. And it's really kind of inviting the question as we start to see those data. When people stopped osimertinib, you started to see those curves get a little bit closer together, and it's really led us as a community to ask the question, should we be doing longer? And so there's trials launched to ask that question, and should we be developing biomarkers to help us decide which patients can come off of the therapy and those who need to continue the treatment?
Yeah, so the ADAURA trial, landmark trial in the early stage setting, the EGFR mutant patient population, just a quick plug again for NGS here. If you don't test your patients, you won't know. And your patient will get adjuvant chemo and then immunotherapy and may not have the same benefit as potentially using a targeted therapy strategy. So Ibiayi, you mentioned an improvement in overall survival, and there was a lot of pushback initially based on the DFS, disease-free survival alone. But now that we see overall survival, is this a regimen you're using in all patients, or are there still some subsets of patients where you don't feel like this is a beneficial potential regimen?
I use it in all patients who have traditional or canonical, kind of the classic EGFR mutation, so L858R exon 19 deletion. And I think then it's a conversation with the patients, because I think one of the criticisms in the overall survival data is access to osimertinib in the patients who got chemotherapy, right? So about 40% of patients who had chemotherapy were able to access osimertinib after progression on chemotherapy. And so I think even if all of the patients were able to access it, I would have been surprised if this didn't lead to a positive overall survival benefit. And so I am offering it to my patients. I do think that it's a little bit, I found that sometimes the toxicities can be a bit different in patients who are receiving it in the resected setting versus in the stage 4 setting. And so I've also encouraged my patients to tell me if they have side effects. And I have been kind of, I'm not hesitant at all to interrupt dosing, decrease dosing, et cetera, to make it more tolerable, because we're in it for the long run.
Yeah, so great point. Common mutations are activating EGFR mutations, historically L858R exon 21 and the exon 19 deletion. If you had a patient, Ibiayi, with an uncommon EGFR mutation, let's say an L861Q, would you use this off-label, or would you wait for the data?
I worry that we will not get the data, right, in terms of a nice prospective study. And the reason that I worry that we won't get the data is that it's hard to lump all of these atypical mutations together. Beautiful work has been done by the MD Anderson group, really subcategorizing these mutations. L861Q is one where we feel confident that osimertinib is effective for. And so I think that if I were particularly worried about the disease, I think perhaps a stage 1B, I might not push the envelope there, but a stage 3 already had chemotherapy, a very kind of proactive patient who wants an aggressive out-of-the-box approach, aware of any kind of toxicities, I think it's something I would consider.
Yeah, I agree. I think off-label use in that L861Q patient is extrapolating from the metastatic setting, I think would be what I would do as well. In the uncommon S768 or, the G719, I agree with you. You may not have significant efficacy, but again, I think trials need to be done, but we may not see those trials happen. You mentioned the 3-year data, and we're starting to now see that in our clinical practice. If you were an early adopter in 2020 of the ADAURA regimen, you're starting to see your patients out 3 years. How do you think about that? And Ibiayi, I don't know if you've had any of those patients in your clinic yet. How are those discussions going? Is there a role to continue past 3 years? Do you stop everyone at 3 years? And like you mentioned, if someone has toxicity, do you ever stop earlier?
Yeah, I have stopped earlier for toxicity. I think the 3-year conversation is tough, right? So you get to 3 years, you get a scan that's reassuring, and you don't know if it's because you're on the therapy, right? Is it because you're on the therapy that we're not seeing any evidence of disease, or is it because the treatment to date has completely eradicated the cancer? So there's that tension there. I would follow a patient pretty closely. I would do scans, and we've actually discussed at our institution, like what rigor for the scans, right? Do you need a brain MRI? How soon should you be checking? And I'd say even at my institution, like with 10 doctors, there wasn't an extreme consensus, right? Some people were like, I need a brain MRI, I need everything at 3 months, whereas others were like, they're at 3 years out from their disease, right? Now you at least should be spreading out to every 6 months, et cetera. So I think we as a field need to define some of these things. And I recognize that there's some patients who won't want to come off the therapy. And I also think it's important for us to mention that, unfortunately, because of the financial toxicity of some of these therapies, there are some patients where I don't think that it's not up to us, right, whether or not to continue the treatment.
Right. There is a trial ongoing looking at 5 years. And I agree, in a high risk patient, like a 3A patient, for example, the risk of recurrence might be much higher. We might want to be imaging the brain more frequently and getting more frequent imaging. But you're right, a stage 1B patient who might have only a 15 to 20% recurrence rate over 5 years, maybe that patient is cured up front. And you mentioned it earlier. I think we need better, biomarkers, better, sort of testing abilities to understand who is cured early and who may need additional testing, or additional treatment. Any insight, maybe ctDNA or anything? Are you utilizing that in your practice, MRD testing, to help guide length of treatment or whether to start or not adjuvant therapy in this setting?
We are not, but I think we can learn a lot from our colorectal cancer colleagues, right? And I think the key is that we can't just apply kind of garden variety assays that we've optimized in the stage 4 setting to this. You need more sensitive assays. Often these are tumor informed, where they've figured out what molecular alterations are present inside of the tumor and using those to try to follow the tumor over time. I think with EGFR, it's a little bit easier, right? Because that EGFR mutation should be present in every single tumor clone that's growing out. And so maybe finding some precise assay, whether it's Natera and other companies. And so we've been, I would say that we've been tempted to do it. I know some of my colleagues have tested it but told their patients that, hey, this is still investigational, right? We don't know how to act.
Yeah, we definitely need further data in this setting. So before we jump to the ALINA trial, just a shameless plug. If you have questions, please put them in the comment section. I'll speak for myself, and I can also speak for Ibiayi. We love the questions. We love the sort of off the wall questions too. So no question is unaskable. So let's shifting from the EGFR space to the ALK space. Walk us through the ALINA trial. Just as osimertinib was FDA approved in the adjuvant setting for EGFR mutant patients, let us know, what is the story in the ALK rearranged population?
Yeah, I said EGFR was almost a standard bearer whenever we think about targeted therapy. I would say that ALK is first in class in terms of like the top of the class in terms of how well these drugs work. We have in the stage 4 setting, we have multiple highly efficacious ALK inhibitors, of which one is alectinib. It's a widely used drug. And so here we're seeing kind of the drug works for the average patient up to 2 to 3 years in the metastatic setting, really inviting the question, should we move it up front? And ALINA is a bit of a different study design than ADAURA, and I think it really speaks to the question that we as a field are still figuring out how we should be giving these therapies. And so ALINA took patients who had a stage 1B to 3 resected tumor. Here the cutoff is 4 centimeters or node positive. And instead of presuming everyone gets chemotherapy, they asked, can we substitute a targeted therapy for chemotherapy? And so half of the patients got now not 3 years, but 2 years of an ALK targeted therapy, alectinib, versus 4 rounds, which is our historical standard, 4 rounds of platinum doublet chemotherapy. Same endpoints, so disease-free survival and also looking at overall survival. We don't have the overall survival data yet, but we have some of those early endpoints that we first saw with the ADAURA study, specifically disease-free survival. And frankly, it looks remarkable, right? We're seeing 30% improvements in the 2-year and 3-year disease-free survival rates. And just to take a step back and say, after about a little over 2 years of average follow-up across the patients, 12% of patients had a progression event with alectinib versus nearly 40% with chemotherapy. That roughly translated to 30 to 35% improvement in kind of freedom from disease progression at 2 years and 3 years. And we saw that in stage 1B all the way to stage 3.
Yeah, so in the ALINA trial, also practice changing, in my opinion, we exclude chemotherapy completely. We saw some data from the ADAURA trial, right, with EGFR, that there was really no difference in those who received chemo versus those who did not. How comfortable do you feel, Ibiayi, with removing chemotherapy completely? I mean, we knocked carbopem earlier, but is that needed for curative intent, or can we get away with, just TKI alone?
Yeah, I think what I would say is that it does give me some pause, right? Because we know that there are some people who the chemotherapy is going to help. It works differently than a targeted therapy when you think about resistance, right? Different ways and avenues for developing resistance. I think what I would say about the DORA data is that while the outcomes were not drastically different, if you look at those curves very closely, there's like a 5% like higher survival if you look at the no chemo versus with chemo. So to me, it does say that there is a benefit to chemo. I suspect most of that is the stage 3 and stage 2 patients. And so I do worry about omitting chemotherapy, but I trust our ALK TKIs. It's just that this is our first time asking an ALK TKI to cure someone, right? In the metastatic setting, we ask it to control the disease. So again, I think it was a bold leap, but it's a study we have.
Yeah, I agree. I think in higher risk disease, stage 3A, for example, even 2B, I feel a little bit uncomfortable about removing the chemotherapy. But in the earlier stage setting, 1B, even 2A, maybe. But again, we need further data in this setting. Well, Ibiayi, thank you for that amazing discussion on the two trials. I want to open up the questions to the group here. What are your most pressing questions on driver mutation positive early stage lung cancer? We're getting a lot of questions in here. Let's, Ibiayi, start with the first one here. For ALK rearrangement, what type of testing are you preferring in your practice? Is it FISH? Is it IHC? Is it NGS?
Good questions, and really reflecting kind of how, like, the evolution of testing for ALK rearrangements, right? So ALK is not expressed in normal tissue, so you can use IHC, which is a simple test to look for expression. You can also use FISH because it's a rearrangement, or you can use NGS. I think it really comes down to what is your turnaround time for NGS and what is the reimbursement, right? Ideally, we would use NGS if we can get it quickly, but if you think that NGS is going to take 2, 3, 4, 5 weeks, or it's not going to be reimbursed, I think FISH should be fine personally, or IHC should be fine as well, depending on your IHC assay, right? Some of them are validated versus others, and sometimes you have to follow up that IHC with FISH. So I almost would start with FISH.
Yeah, but how good are we at identifying any individual mutation in a patient or predicting what mutation a patient would have? Why the move away from piecemeal testing to broad panel NGS?
Yeah, I think people did that study, right? It's really funny if you go back like a decade or so, where people did the study where they presumed that people had EGFR mutant lung cancer and then gave everyone a first generation EGFR TKI and found out that it wasn't the best way to do it, right? You really have to be molecularly precise, do the testing. There is overlap of particular molecular alterations with certain kind of clinical pathologic characteristics. So we can't presume what a patient might have, and so we really have to do the testing. And I also think that the test is only as good as the operator, right? And so that's why, in some ways, FISH, I would make sure that you're in a center of expertise where you know someone, where the pathologist feels comfortable doing that assay. Because I have seen false positives and false negatives.
Yeah, and then also, you can't, tissue is the issue here, right? And you can sort of use up most of your tissue quickly if you do piecemeal testing. Broad panel NGS, in my opinion, is more cost effective, also more effective for patients in identifying the breadth of alterations as opposed to only looking maybe at the most common alterations. Because we do want to know if a patient has a RET fusion or a ROS1 fusion or an NTRK fusion, for example, in the early stage setting. It may help guide treatment, particularly for clinical trial enrollment. So with that, Ibiayi, I want to thank you for your time, and I want to thank the participants for participating in this activity. It's been a phenomenal discussion talking about the early stage setting, how important NGS is in this setting, and really the prospective data, randomized controlled trials, phase 3, published, showing the benefit, survival benefit for adjuvant osimertinib in stage 1B to 3A, and in the ALINA trial, showing the benefit, at least disease-free survival to date, for adjuvant alectinib. We hope to see the overall survival data shortly. I would recommend everyone just to see the comment section to claim your credit for this event. Click on that link in the comment section. Ibiayi, you get the last word.
Oh, I just want to say thank you, everyone. And this is a rapidly evolving, very exciting area. So really a topic to stay tuned for.
Thank you, everyone. Have a great day.